Greetings, friends and followers. This is Nurses Talking. I am Del Barzi. As always, if you like what you see and hear, subscribe. Leave us a comment and let us know what you think. So here on Nurses Talking, we speak to nurses anywhere in the world and at any stage in their nursing journey, from students to retirees and anywhere in between. Today, it is my great pleasure to welcome John Bell. John is a master prepared registered nurse with more than 25 years of emergency medical experience and 15 years of experience in surgical care. He's combined his backgrounds to specialize in vascular access education and built a successful vascular access specialist team. John went on to gain experience as a clinical consultant, working for multiple companies to support vascular access device training. He received board certification in vascular access in 2018 and is actively involved in the Association for Vascular Access, serving as a board member and officer in the past. He has presented at multiple national and regional conferences, speaking about vascular access, process improvement, and research. John is currently the director of the emergency department at Mount Desert Island Hospital. So thank you very, very much for joining me today, John.
Thank you, Dale. Good to be here.
It is my absolute pleasure. Firstly, why are you a nurse?
That is a tale of serendipity. I never set out to be a nurse. I grew up in the South, and even when I did become a nurse, it was still much more female dominated even than I think some other areas of the country for different reasons. And so culturally it was just something different. And I remember as I became a nurse, I had this very weird thing where one of my daughters said, who was about 6 at the time, she said, "When I grow up, I want to be a nurse like Daddy." And that just kind of was like, kind of, and again, I mean, I just grew up in a culture where nursing was primarily females. And so how did I get there? I fell into, first of all, into EMS. I was actually headed towards law school and stumbled into EMS, kind of caught the bug, started doing that, became a paramedic. And then again, this same daughter, actually, when she was born, we were in the birthing room. My wife was kind of in this long, slow laboring process. And there was a nurse trainee who was finishing up. So the nurse preceptor was kind of free. And we were sitting over in the corner, just kind of talking. And she, her name was Jill. And Jill said to me, we talked for a while, and then she said, you really should go to nursing school. And that sparked something that over a couple of years, I did end up going to nursing school, transitioned, was able to find her in the cafeteria one day of this very large hospital and go up to her. And I hadn't seen her since my daughter was born. And, so this like 6 years later, I was able to go up to her in the cafeteria and say, "Hey, Jill, I don't know if you remember me, but you encouraged me to go to nursing school." I did. I'm a registered nurse here at this hospital now. And so that's how I got here.
Wow, how cool is that? That's really, really cool. So as you said a couple of times, you went into nursing school when, especially where you were located, it was predominantly female dominated. What was the challenge for you in that arena?
I think the one challenge that I would say that I've really experienced is that I think that there are times when there is a little bit of a bias against males, and almost as though, there's other places where males have an easier time getting ahead. This is kind of our camp, and this is where we get ahead. So don't horn in on our part. And I do understand that. And it's just it's something, it's never been insidious. Clearly I'm in a leadership role now. I've had a successful career. It's just an interesting thing. And it's, you know, without speaking out of turn, it's a minority thing that happens to all minorities,
Mhm,
whatever that minority group is.
mhm,
Uh,
mhm,
I will just say, to go back to that, the interesting thing was leaving the Southeast and moving into the Northeast. It was interesting to go from a place. At one point, there were two male nurses in the emergency department, in this large emergency department. I moved to the Northeast and it was about like 20% male.
mhm.
Um, and, to go from maybe like 5% male to 20% male was a big shift. So those are just interesting things. Um,
Yeah, yeah, yeah,
I
yeah.
do think that I think the other thing about gender in nursing, I think that there's been an advantage of sometimes when you get a lot of, and I guess again, this is something that works on both sides of the coin. Sometimes you get into places where you kind of get some cliquishness between groups of females. And I think sometimes as a male, it's easier to kind of get outside of that and try to maintain
Yeah.
relationship with
Some,
both groups and not get drawn into whatever this tension is between the two groups.
yeah,
So that's an
yeah,
interesting observation. Let me say
yeah.
one other thing about it too. The other thing that I think is interesting, because I just thought of this, there's an interesting dynamic, gender dynamic with doctors. And
Mm-hmm,
sometimes male doctors and male nurses, I've had some great doctor colleagues of both genders, but sometimes there's some weirdness, but different. I
yeah,
sense them treating me differently than female nurses. And with female doctors, there's this whole other dynamic that's kind of interesting because um, uh, they sometimes don't get on well with female nurses, but they get on better with male nurses. And meanwhile, in the room, what's happening is I go in and I say, Dale, hey, I'm John. I'm your nurse. I'll be taking care of you today. A female doctor walks in and she says, hey, Dale, I'm Dr. So and so. I'll be, and she'll turn to me and say, Doctor, what do you think is going on? And that's a jarring thing. Like I'm like, we have clearly identified ourselves, and you're doing this
yeah,
gender perception, even despite the overt messaging. And I always
yeah.
feel bad for my female physician colleagues. And I'm like, she went to medical school for 12 years to be standing here, and I'm a little insulted that you're assuming
But yeah,
something based on our gender. So
yeah, 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 yeah. I I get it. I get it. And one of the things that I always found jarring, in fact, and I kind of try to advocate for, is that when we speak of men as nurses, we say male nurse, right? And I always felt like we shouldn't say that. Just say nurse, because that really just sets you apart. As if there's something different. You're a nurse.
yeah.
But yeah, I get that. So currently you're in the emergency room. You like the adrenaline pumping thing, huh?
Um, I I I kind of, I mean, I think all ER nurses, I think when you're young, you're drawn into it for the
Yeah.
adrenaline. As you go on, it's like, oh, not another code, not another trauma. Um, I think over the course of my career, what keeps drawing me back to emergency is just the breadth of it. You can go from working on a 90-year-old to working on a 9-day-old patient
Yeah.
in a,
Yeah.
in a split second. And
Yeah.
everything from emotional issues to trauma to medical issues, and you get the most bizarre. I was just talking with a new grad nurse yesterday, and I said, one of the things that's consistent in my career is every time there's a little voice in the back of your head that says, I've probably seen everything now. And we know right away that's not true, but every time that little voice springs up, it's like the next shift, you see some crazy thing that you go, wow,
Yes.
like I never saw that coming. I didn't think that could happen.
Yes,
So
yes, yes, yes. And it does not matter how long, how many years you do this, that will always happen.
yes.
That will always
The
happen.
other thing that's interesting is I'm now I've kind of gone from this very large, I started out in an ER that ballooned up to about 87 beds. And then I jumped down to something that was about 38 beds. And now I'm in an 8-bed ER. And even in the size, like it doesn't matter how big or small it is. It could be 200 beds, it could be 2 beds. You still get those crazy things walk through your door, and you're like, oh my goodness, in 30 years, I've never seen this before.
Yeah, yeah, exactly, exactly. So, but vascular access is your thing now.
It is, and as you did in the introduction, it's a journey I could never have charted. Um, it's the interesting part of it is I I I burned out. I burned out in the ER again. I started in a very, very high stress ER.
Mhm,
Um, we had about 75% of our staff were travelers. The travelers were doing charge and triage, and because we had no staff nurses,
mhm.
it was pretty crazy, and I worked crazy hours. I just burned out, and I loved it, but it was killing me. And so I kind of had an interest in the OR. I went to the OR full time for about 3 years, and really, was able to heal, recover. Ended up going back to the ER, and I remember thinking at one point, like, the OR is so different from the
Yeah,
ER. Like,
yeah.
what do you ever do to cross over? And over time, it ended up being that things I had learned about procedural um, sterility, and how to be a scrub nurse, and doing some vascular stuff in the OR, um, was able to come back to the ER and help me start helping. I started out in two ways. First of all, I started learning ultrasound guidance, to access for peripheral
Yeah.
IVs. And then I also started helping out the doctors in doing central line placement, because their sterile technique was a little lacking. And so I
Hmm.
I had this epiphany one day that if I just go in, if I scrub in and set up for them the way I would do in an OR, and then if I gown and glove them, I can probably take out most of the
Yeah,
places where they're breaking sterility. And so then started helping with these central lines, kind of became more and more, and finally they're watching me do these IVs with ultrasound, and so they're finally like, hey, just like, I'm here, just put the line in and I'll stand by and you do it.
yeah,
So
yeah, yeah.
that's kind of how those two came together. And I really love, I got to say, what I love about vascular access, um, there's a technical component. There was a component to it where I just found myself in a place where I could do things that some other people just didn't have the background to do, again, because of the OR. And um, but what really draws me to vascular access, what I always go back to is the patients that you meet, that you go in and they say, look, every time I get stuck 8 times. Don't feel bad when you miss. Usually they end up calling the anesthesiologist in. I've had a line in my neck. I've had 5 picks. They start telling this story, and you go in and you upskill and you just use ultrasound, and you get the IV in on the first stick. And they go, I mean, I've had patients literally almost crying, saying, nobody has ever gotten me on the first stick. And that is what drives that, the ability to get patients the care they need, in the best way possible, and not to put them through an hour and a half of being stuck 8
Yeah,
times.
yeah, Yeah, I can get that. I can get that. And also as I was reading, I was thinking that there are so many different devices now that can be used. I could see where, a lot of education is needed as to implanting these things and taking care of them and all of that kind of thing.
Yeah, it really has you know expanded quite a bit. There's a lot of confusion in the marketplace because we have some really weird terms. We have companies coming in with marketing
Yeah,
terms that are confusing to doctors and advanced
yeah,
practice providers and nurses. And it's an interesting thing. There certainly is great research out there that demonstrates um, that having specialists that specialists can really make an impact in vascular access. At the same time, there's not a volume that can support every single hospital having vascular specialists.
yeah,
And
yeah,
when you look at millions of IVs placed every year, I don't think anybody would argue that having a specialist that does
yeah,
nothing but do access all day, every day, do those lines would be the best thing. But when you're talking about millions of peripheral IVs, can you
yeah,
have that many specialists?
yeah,
Does the medical community is the volume going to support that? And probably
yeah,
not. There's always going to be that generalist place in
yeah,
vascular access.
yeah. But yeah, I can see why it would be a big thing. It would be a big thing. As someone who is one of those patients that you talked about that is like, oh, I don't want you to stick me. I would most certainly welcome that as a patient, yes. What would you like to see change about nursing?
Um, I think that there's a lot of things, but while we're talking about vascular access, let me just stick with that because I
Yeah,
think that this is actually what I've given a lot of my time and some research to, and what I've spoken about. And that is, as I just alluded to, I think that there's always going to be a place for the nurse generalist to be doing vascular access.
yeah,
You know, uh, the 18-year-old with big veins that you can see from across the room. We don't need a specialist to come in
yeah,
and get an IV so that the patient can have knee surgery or have a
right.
workup in the ER. Um, Somebody like yourself that has a history of having some difficulty, the really bad thing that's just kind of accepted that I always like to challenge is I almost every place I've been, the policy says Dale needs an IV, so you go in and you try twice, and then you get Nurse Sue and
Yeah,
let her try twice, and then we'll get
mm,
Nurse Bill and he'll try twice, and
yeah,
then we'll think about doing something else. And I started about 10 years ago just thinking through like, we've got to be smarter than that. There's got to be a way that we can objectively identify these
yes,
difficult patients and then jump to
yeah,
the higher level. Um, and that's what I've really, that I would love to see changed. Um, and have done some work. There's actually some great scoring tools out there, and I've published on one that I kind of adapted that helps nurses to identify. Um, just real interesting aside on that.
yeah.
One of the studies that I found in 2018, they did a study in Italy. I think you'll find this interesting, Dale. They did a study in Italy on identifying difficult IV access that we call DIVA. Uh,
Mhm.
uh, Not for that they're divas, but just difficult
Got it. Got it.
vascular. The Italian study said that experienced nurses do a better job, right? All it said was there is such a thing as nurse gestalt, right? As an
Yeah.
experienced nurse, you walk in and you go, "Oh, this one's going to be tough," or you walk in and go, "This will be easy." The
Yeah.
inexperienced nurse doesn't know that,
Doesn't know.
and
Mhm.
so they're more prone. Like I've seen nurses, I go, why did you even try this? You should have called me immediately. This patient should never be stuck without ultrasound. And so that's what I'd like to see change. I'd like to see that kind of working smarter, not harder, for people to,
Yeah,
and again, that right now I think we have subjective um, assessment.
yeah,
And so the nurse goes, well, I think I can get this. And on an objective scale, you were never going to get that line.
yeah.
So we have these tools, just like we have fall risk assessment tools and suicide risk assessment tools and all these other things, right? And I would love to see that become ingrained in nursing. And then the problem with those tools is you have to have the team to back it up. It
Yeah.
doesn't do me any good to say, man, Dale's really hard. I need somebody else to stick her if there's nobody out there that I can pick up the phone and call. So
Right,
that
right.
would be high up on my list of things I'd like to. And I'm
I
going to
got
keep talking about it, and hopefully I'll move the needle at least a little bit.
Listen, that is the goal of me. One of the goals of me doing this is to help as we talk about things. Help us first of all identify those things that we want to see change, or the things that satisfy us, how we want to see things, and maybe, just maybe, start to move the needle in the way we want it to go. Because currently, what a lot of us complain about is that, the things that affect us most, affect us and our patients most, are not being decided by us.
Yes. Yeah. And it's even hard. It's hard to advocate for
Yeah,
yourself.
yeah.
That's kind of that's probably my next thing that I talk about quite a bit. Um, I had a blood draw yesterday, and the phlebotomist cleaned my skin. And then what did the phlebotomist do? They reached back in and they
Let me-
touched and felt the vein, and then they
Yeah,
stuck. So they cleansed my skin, then they
cleanse,
continued
and
to do my
then,
skin, and then they breached my skin.
yeah.
And I'm sitting there like, I know that they're going to do this. I know I should say something. I should advocate for myself, but what am I going to do? It's hard.
Yeah, and in doing that, you also know that it's not going to change what that phlebotomist does for the very next person. They may roll their eyes and do what you wanted, but it's not going to change for the next person.
Yeah.
It needs a little more than that. It needs a lot of understanding as to the process.
Yeah.
Yeah, yeah. We're talking a lot about self-care. You told me that you burned out. You told me you burned out. I know that a lot of that burnout comes from the situations, the environments in which we work. I also believe that some of it comes from us just not taking care of ourselves. We want to take care of everybody else, and somehow we think that if we just keep going, we're going to do it. Well, the time is going to come when we can't. So, what does self-care mean to you?
Well, let me quickly just address that too. I think one of the things I struggled with in burnout is um, you and I could be in the same department doing the same work day after day. The way you react to that stress and the way I react to that stress can be completely different.
Yeah.
Um, and I've seen people that were 40 years into their emergency nursing career, and everything just was like water off a duck's back. And I'm like, I'm dying here. And this woman's 20 years older than me, and she's unfazed. Like, what's wrong with me? And we have to recognize that it's nothing wrong with me or that I'm lesser. It's how we deal with stress. Um, and everybody has a different way of dealing.
Hmm.
Everybody has
Yep.
different um, reserve capacity to deal with stress. I think that self-care, I think I've always had um, uh, great ways of dealing with stress.
Mm,
It starts, my wife, we've been married for 31 years, and she's always been great from the very earliest days in EMS. I could come home and talk through stuff that happened. And that's always been kind of my first line. Um, I think that um, my church family is a part of that. uh,
Mhm.
at the end of the day, um, it does kind of come down to what you're doing with it. And I think it comes down to me, self-care is that ability to recognize when you're using up your reserve and you have to change something and get to a place where you can start rebuilding that reserve.
Mm.
And the things that fight against that are survivor's guilt or abandonment. The idea like I'm part of this team. If I leave the ED, I'm leaving my friends and colleagues to deal with this stress.
Yeah.
But there's times I actually got to one point where in looking back on that time, my big regret is I didn't recognize how burned out I was, and I didn't recognize how toxic I was becoming. So I was staying there to help out my friends, and I was actually hurting them more
Good.
because
Yeah.
I was unable to deal with my stress and I was becoming toxic. And again, until I got out of that and healed from that, then I was able to reflect back and go, "Oh my goodness,
Okay.
I was becoming that toxic person that nobody wants to work with." And if when you have real colleagues and friends that love you and respect you, it's very hard for them to look at you and say, "You're toxic and you need to
Yeah.
change something."
Yeah. Yeah.
Um,
Yeah.
and the flip side of that is I wish that somebody had said that to me. I still take total ownership in the fact that I made decisions and I didn't recognize myself. I would hope though that if somebody had pulled me aside and said, "Dude, what is going on? Like, you seem really unhappy," um, that would have helped me move on to the next thing. And the
Mm.
great thing about nursing, though, and one of the great things of again in the realm of self-care, um, the first time I burned out, what did I do? I went to another part of nursing and I recovered. And that's the
Yeah.
beautiful thing about
Exactly.
nursing. There's so many avenues in nursing. There is no reason that you need to stay in an OR, an ICU, ER, any part of nursing and stay there and burn out. Go someplace else. Find
Yeah.
a way to use your calling and your knowledge and your passion and your care for others in a productive way that will be healing and productive for yourself as well as allowing you to care and heal other people.
Yeah, yeah, yeah. And that is one of the reasons I do this. I really want nurses to see what nurses are doing, what the possibilities are. There are so many nurses who I see who are feeling stuck and as if they can't move. And I really want them to see other nurses doing other things because yes, you can move. That energy and that money and that time and all of that that you spent becoming a nurse, it's not wasted. You can use it in so many different areas. And so I want them to see other nurses doing just that.
Yes.
What advice would you give to someone who wants to be a nurse today? Because we're talking a lot about I just looked at something that you reposted. Actually, I think about the American Nurses Association going to Congress and saying if you want the nurse to change the nursing shortage, you have to change the workplace. And there's so much of that kind of thing out there. What would you say to someone who wanting to come into this?
Yeah, I think that in that vein, I think that we have to be careful. Sometimes we focus on the problems in our profession, in our career, and there's certainly a place to do that, and to talk about how we can make things better. But we can't focus on the negative so much that I mean, one of the ways that we
Yeah,
get salvation is by bringing more people into this profession. And if we drive people away, we're not helping ourselves as a profession. We're not helping our greater community, our society, because we need nurses. Okay.
yeah,
We've, you know, Florence Nightingale made that case 170 years ago, and it's still true
and it's
today.
still.
We can't
Mhm.
blow that up. Okay. So I still think this is a great profession. I still think that it's so wide open. There's so many different scheduling varieties. I just talked to a nurse yesterday who's working a true Baylor. That's coming back and forth because of the
Yeah,
shortage. There's just so many great things. And at the end of the day, we get to take care of patients. In the emergency department, you see people at their absolute worst. You see people at rock bottom,
Yeah.
and you have the chance to intervene and to make a small difference. And even if we don't save their life, if we can make the end of their life better by being there and being present and holding their hand, or
Yeah.
doing oral care or something, we
Some
can make a difference for them. We make a difference for their family. And there's nothing that can take away from that. I don't care how broken the system is. I don't care how corporatized it becomes. I don't care if you feel like you're not being paid. At the point of impact between me and a patient or me and a family member, you can do something that is priceless.
those words. On that note, you can do something that is priceless. Thank you so much, John, for this conversation. I can't think of anything I can say to top that. You can do something that is priceless. Thank you so very much for this conversation. I truly appreciate it.
Well, thank you for having me, Dale. I really always enjoy talking to nurses.
It's my great pleasure. Thanks, John.